Good morning. I'm Al Charbonneau, the Executive Director of the Rhode Island Business Group on Health. Thank you for joining us this morning in this important employer discussion, the cost impact of COVID-19. I'd like to begin by thanking our sponsors who support RIBGH's work, including this morning's discussion. I know I speak on behalf of the RIBGH board and our members when I say we are truly grateful to our platinum sponsor, Mercer, our gold sponsors, Blue Cross and Blue Shield of Rhode Island, Hillbrook, New England, United Healthcare, Neighborhood Health Plan, Tufts Health Plan, and Aetna, and our silver sponsors, USI Insurance Services, Merck, Gallagher, and Delta Dental. And equally importantly, I want to say thank you to our growing group of 90-plus companies representing over 80,000 employees who are our members and sponsors of this event as well. It is now my pleasure to introduce Kate Kennedy, Vice President, Employee Benefits, USI Insurance Services, and a board member of RIBGH. Kate will introduce today's speakers. Kate?
Good morning, everyone. Thank you very much for taking time to join us this morning. As Al mentioned, I'm on the board of Rhode Island Business Group on Health and have been for, I believe, 9 years now. So it's our pleasure to be with you this morning. I'm going to go ahead and share my slides, and then I'll be introducing our panelists in just one moment. Okay. So as Al mentioned, we are talking this morning about the cost impact of COVID-19, which I know is a topic that's very important to many business leaders, HR, and finance leaders at this stage of the game. And before we introduce our speakers for this morning, just to sort of put things in a very broad context, I realize that this slide it's a bit of an eye chart, but the reason I brought it up is just to look back over the past 3 or so months, and just to think about when this COVID issue hit in sort of beginning and middle of March. From a business leader standpoint, the initial focus, of course, as you all know, is figuring out how to manage your business through the initial onset of the pandemic. And then, of course, there were the various legislative actions that were taken, the FFCRA with extended leaves, as well as the CARES Act. I'm sure many of you looked at or applied for the PPP loans. And then, moving into April and maybe into the early May timeframe, the focus for employers has been for those who, had to either discontinue operations or move to remote work. The focus has been on a return to work or return to the premises strategy. And this chart that I'm sharing is a timeline that represents the actions that USI has taken to support our client base and the broader population as well. USI, for those of you who may or may not know, we are top 5 in insurance brokerage and consulting firm. And when the COVID crisis hit, we moved to create what we call USI Steer, which is essentially it's a working group of our leadership steer through academic and economic recovery. And the items in red there indicate all of the various compliance updates, communications, and webinars that we've been hosting. And certainly, if you were interested in more information, you can look at USI's website. So at this time, it's my pleasure to introduce our 2 speakers this morning. So first of all, we have Patrick Canavan, who is the New England Employee Benefits Practice Leader. Patrick has 25 years of experience in the employee benefits industry, 9 years at USI. In his current role, he manages our consulting teams both regionally and locally. And he also serves on the executive team for strategy planning and market relationship. Nick Allen, who is our National Practice Leader, Customer Analytics. has 19 years of experience, 10 years at USI. Nick's expertise lies in helping clients understand and mitigate enterprise risk with their healthcare plan. His experience ranges from mid-market to jumbo client consulting, sales, and service. Nick is a fellow of the Society of Actuaries, a fellow in the Conference of Consulting Actuaries, and a member of the American Academy of Actuaries. In his current role, Nick leads architecture and development of USI's proprietary actuarial and financial tools. So at this point, it's my pleasure. I'm going to turn the podium over to Patrick Canavan.
Great. Thank you, Kate. So what we want to do is we want to start by framing the cost issue stemming from the COVID-19 pandemic. So first off, there's the obvious unforeseen utilization that was brought upon by the COVID epidemic, including the testing and treatment of COVID-19. Now, in addition to those people who were COVID positive, this would also include a great number of folks who went through the testing process and tested negative. So there is an increase in the utilization that we've seen as a result of that. Furthermore, there is those hospitalization costs, and this is really the vast majority of the claims that we're seeing, both for ICU and non-ICU patients. Now, for those people who have complications or comorbidities, this is a particularly sensitive issue and particularly costly. And then finally, due to some of the federal mandates like the CARES Act, as well as some of the steps taken by all of the Rhode Island carriers to cover treatment of COVID in full, there has been minimal or no employee cost sharing to the plan, which means those costs are now being borne by the plan. On the other hand, there's been a dramatic utilization reduction for elective or non-urgent, everyone says elective, what they really mean is non-urgent services. Those things could include like elective surgeries, PCP, specialty care, ER visits. A lot of those visits and most of those visits have been down dramatically over the past few months, resulting in a claims reduction. Now, unfortunately, there's also been a reduction in those preventive care visits and age-appropriate screenings, which is something that we're going to get into later on in this presentation. But that reduction in services, some are those low-value services like ER visits that we've heard from many times on the business group on health, and then some are those higher-value services like the preventive care. Now, another thing that we've seen is a dramatic increase in the telehealth utilization. There was a recent Forbes article that cited that in 2019, only 11% of Americans use telehealth, whereas currently 46% of Americans are now using telehealth, largely due to the COVID crisis. So that's a dramatic increase, what we're seeing in the telehealth utilization. In addition to that, there's been an increase due to the expansion of services available through telehealth, things like behavioral health. A number of the carriers have been able to promote behavioral health and additional services through telehealth, and we only see this as growing. The good news is those low-value services like ER visits are now being replaced by those higher-value services of telehealth or lower-cost services like telehealth. From a long-term perspective, there are some questions that no one has the answers to yet. For example, what will be the reschedule rates of these elective procedures? Are these services going to be deferred or are they going to be canceled? And the concern is, will some of these procedures now become more major? In other words, like a acute procedure, like a cortisone shot, will that cause further deterioration into something more acute, like say a knee replacement? On the positive side, the question is, have members used the shutdown to address certain health behaviors with things like diet and exercise to avoid needing that acute care? So that would result in the cancellation of services and not the deferral and possible increase of services. Looking at it from a wellness and a preventive care perspective, we need to identify what's going to be the long-term impact of that decreased focus on wellness and preventive or early intervention care. There's been a number of employers that are looking at suspending or limiting their wellness programs. And the issue there is, will it cause cost pressures due to a lack of things like immunizations, the early detection of chronic diseases from annual exams, like say diabetes or hypertension, and also the lack of those age-appropriate screenings like cancer screening. We have spoken with one carrier who had indicated that just in the months of April and May alone, there were over 120,000 canceled mammograms. So the question is, when will they occur and when will that diagnosis take effect? We do have one exhibit that we will want to share with you about the impact of this. This will show the later diagnosis of breast cancer and the survival rates. We've highlighted stage 1 and stage 4, and the difference between these two stages is dramatic. That average cost over a 12-month period increases 66%, and over 24 months, 88%. And more importantly, the survival rates decrease from over 99 to 22%. So it is vitally important for employers to maintain wellness promotion at this time, even with the remote workforce and the competing priorities. So with that being said, we kind of wanted to set the stage and really get into the meat of the presentation. And I'm going to turn it over to Nick Allen, who's going to review the COVID cost estimator that we put together.
Thanks very much. And thank you for the lovely introduction, Kate. Sometimes I don't really think about my own accomplishments until I hear somebody else say it. So that was kind of a nice bump this morning. I appreciate that. Now, so Patrick mentioned some of the really important considerations about what's happening and what's not happening. A lot of people are asking themselves, well, how does this impact me? What is this going to mean for my cost in the year 2020? We're thinking about that right now, and we're thinking about 2021, but you might be surprised. For 2020, by and large, across the country, we're expecting mostly a flat or slightly favorable change to your expected costs. What I want to do is walk through some of the assumptions about how we got there, and then show you an example of a calculation, and you can follow along. So there is, from a social perspective, obviously, COVID-19 has been terrible. From a purely mathematical standpoint, it's kind of an interesting problem because there are so many different key variables that make this a wide range of possible outcomes at the end of the day. But some of the ones we've looked most closely at are the infection rate. And as we look through these and talk through these assumptions, know that when we set ours, it's a mix of source data, research, information we're getting from places such as the Institute for Health Metrics and actuarial judgment. So as we walk through, the infection rate is just what it sounds like. It's the percentage of people who will actually contract COVID-19 over the course of the year. There's the percentage of infected membership that require treatment. So you might be surprised to hear, I know everyone has heard that not everybody that contracts COVID-19 is symptomatic, and that's very much true. But even further, not everybody that contracts COVID-19 requires a doctor or hospital visit. Some people have what others might consider mild symptoms or just cold-like symptoms where they end up staying home. And in fact, either being asymptomatic or having mild symptoms is the majority of people who get COVID-19. There is a severity of illness for those who do seek treatment, right? We're talking about what does it cost for somebody who actually does have to go to the doctor or has a hospitalization because they get sick with COVID-19. We looked at that. Patrick mentioned there's not just the people who get infected, but there's the people who are worried that they might be infected. And that's a significant amount of the population. I wouldn't quite call it paranoia costs. Like I said, we call it worry. It's more just there's so much disease out there right now, and the implications of somebody get it could be bad, that people are just being extra precautionary. So we've considered those folks. We've also considered, as Patrick mentioned, the percentage of people who are avoiding healthcare services at this time. It's really interesting, and that very much, as you'll see, offsets the cost of the people who do have, who are infected and who get sick. And last, it's not just that there's a percentage of people who are avoiding membership, but we have to consider what types of services that are being avoided. And we talked about elective services. Those are ones that could be deferred until later on, and that's very much what we're seeing. So as we get ready to look at an example in Rhode Island, what I did was took a sample group of 1,000 lives, and you can turn the page for me on this one. I'm going to walk through a kind of line-by-line example of how this might work. All right, I have to move my little picture window so I can see all these things. There we go. So on the top line is, again, imagine a group that has 1,000 members. That could be one that has about 500 employees or contracts and assumes a family size of 2 members per family. The infection rates, and these are very much realistic assumptions across from an optimistic view across to a best estimate and then ultimately a pessimistic view. These are very much realistic infection rate numbers for Rhode Island. These don't come from me. These come from the Institute for Health Metrics, and we've been buying into these. There's been a little bit of change in them from the time that COVID first started early in the year till now, but they've been pretty steady now for the last several weeks. So on the optimistic side, the infection rate 5%, pessimistic up to 11.2. That means that if you're a 1,000-member group, you could expect anywhere from 50 to 112 of your members to contract COVID-19. Now, that's just a range, all right? You could fall somewhere outside that range if you're unlucky, if you're in an industry that has a certain amount of people who are going to be in close contact with those who are sick. So this is a range. It's even a range of an average, if that makes sense. So just know that this could be, your results could be better and they could be worse, but this is typical of an optimistic to pessimistic view. Now, of the 50 to 112 people that are actually going to contract COVID-19, only, as you'll see, 20 to 40% of them will require some kind of treatment. That means all the rest will either be asymptomatic or they'll have symptoms that are mild enough where they'll be able to take care of that sickness at home. So of the people that are infected, the 50 to 112, only 11 to 44 we expect to actually require treatment. Now, this next line, I'm just going to talk about for a minute. I put in here the average cost of illness for those who do seek treatment. Now, when we read in the newspapers and hear in the news about what it costs to treat somebody at a hospital, whether it's on a ventilator or not, and those costs getting to in the $50,000 to $70,000 range, those are actually not wrong. But in here, in this $6,000 to $7,000 average that you see, includes people who get sick, but then just go to their primary care physician. So the $6,000 to $7,000 is an average of the people who are just going to the physicians, the people who are going to urgent care, and those who actually are hospitalized. And those hospitalization costs, whether it requires the use of a ventilator or not, are quite costly. But again, they're averaged into this big number. This number also includes the cost of testing. So when you look at the members requiring treatment and the cost of those who do seek treatment, that totals out to, again, for a 1,000 life group, anywhere from $65,000 a year to $300,000 for the year. Now, remember those numbers for me, 60 to about 300,000. That's the cost of our infected membership. So if you can move to the next page. I talked also about the worried membership. These are people who are worried that they're infected, but they're not actually infected. So maybe they came down with a flu with really bad timing, or maybe they came into contact with somebody and they're worried that they have it. So they go to the doctor, or they go to an emergency room if they have the flu and they get tested. They go through the normal course of treatment, but these people, we're assuming, are not being hospitalized. They're just going through the healthcare system, and we're assuming that they're just worried and not actually infected. That represents anywhere, and you can see this on the second line, from 2 to 6% of your membership population, which sounds like a small number, but in reality, it's not a small number. And if you look across the population of the United States with about 300 million people, 2% of that is going to be about 6 million folks. So it's big numbers in the grand scheme of things. But fortunately, their cost is not that bad in the grand scheme of things, averaging anywhere from about $500 up to about $600, which again is an average of cost between a PCP visit plus a test and those who do their visit through urgent care or the emergency room. Total cost of worried members for a 1,000 life group, anywhere from $9,000 to about $35,000. Again, remember those numbers. It's a lot to remember, but believe me, I'm going to show it all to you at the end. So as we go to the next page and talk about those who are avoiding care, these numbers might surprise you. So out of 1,000 members, we think, again, and this number is for the percentage of membership who are avoiding elective procedures. It's variable based on the state you're in and based on how bad the infection rate is. So depending on the state you're in, this is what we have assumed for Rhode Island, anywhere from a 40 to 60% base of membership who is now actively avoiding elective procedures. Now that's a pretty big number, and that number it's not made up. We have some case studies of catastrophes and how people have responded to those catastrophes in terms of healthcare utilization. We use Hurricane Katrina as a model for that, and what we saw after Katrina was a real drop off in the use and utilization of elective procedures. Of those, the percentage of healthcare costs themselves that are elective, it's about 30%. Okay, so about 40% of the membership is avoiding 30% of cost. And of those costs that are ultimately canceled, now Patrick mentioned the idea that we have to think about not just costs that are avoided, but those are rescheduled. So when we look at those that are ultimately canceled, it's anywhere from 50 to 30% of it. So there's people who are actively avoiding procedures, the value of the procedures that are being avoided, and then ultimately those that are going to be canceled versus just avoided. If they're avoided and rescheduled later on, it's neither a savings nor a cost. It was going to happen this year, and now it's going to happen next year. Really, we just move dollars around. So it's really just the ones that were canceled that we're looking to find a savings. We consider the average healthcare cost per member. I put in about $300. That could be low for you, or it could be high, kind of depends. So all those elements considered, the expected savings from elective procedure avoidance for a 1,000 life group is going to be about $70,000. And what's interesting is that number doesn't really change across optimistic to pessimistic, because what you'll see is that as the percentage of membership avoiding elective procedures goes up in that second line, the assumption for the percentage of avoided procedures that are ultimately canceled goes down, and those two assumptions kind of cancel each other out. So we're expecting in the neighborhood of $70,000, regardless of what scenario you're in. So when we look at all those three pieces together, A, B, and C, what you'll see is that it adds up to, as I mentioned before, something that is slightly favorable, meaning in that fourth line, an $87,000 save for a 1,000 life group, to, on the pessimistic side, a $200,000 bad guy in there. Now, this is why we have this best estimate. The expectation is that it's flat or slightly negative, but again, circumstances are different for each group. Different groups have different demographics. Again, they have different industries. Some are closer to areas that have been hit harder, and some people are just going to get unlucky. And that's kind of how these things go. So I don't like to try and pin it on one number. I like to say, yeah, there's an expectation, but many people will fall somewhere within a window of that expectation, and we want to obviously do that analysis. So that's what we're seeing. Very much so, even though there's a higher average level of infection in Rhode Island right now, nationally, we're seeing trends that are very much the same in terms of the best estimate. It's about flat or slightly favorable, but the optimistic and pessimistic views are compressed around the best estimate a little bit tighter. So that's what we're seeing nationally. And Patrick is now talk about the impact of that from the point of view. Oh, actually, I have a couple of questions. And after that, Patrick will talk about the impact from the carrier perspective. A couple other considerations. People are asking, should they be making mid-year adjustments to their cost projections? Briefly, we think no at this time, though again, there might be exceptions for people who know that they've been hit particularly hard. For people who are going to get a benefit of a savings, take that surplus that you're going to have at the end of the year, roll it into the next year. That'll be a good renewal for you. For people whose population age is average is higher than most groups, what that means is probably with a model like ours, what we have, and we'd love to run it for you, just lean more towards the pessimistic side of the estimates. And by now you probably know where you're going, but if not, that's something that we can talk about. People are asking also, how much more data do we need to know if we need to make revised estimates? By now you'll have enough information. We think April and May are going to give us enough indicators to detect if there was a COVID-19 related cost impact to your business. June is better, and obviously the more of the data, the better. But we do think April and May will be enough for you to work with a business like USI, for example, to detect and quantify that impact. And then last, about the effectiveness of wellness plans, this is another question. People are asking, how will the fact that our wellness plans might be more difficult to administer ultimately affect our costs this year or next year? The answer is, we're not exactly sure. We know, what we do know for sure is that people who are participants in aggressive wellness plans whose effectiveness has been dampened by the effect of COVID-19 will miss screenings, as Patrick pointed out. And because somebody in Rhode Island or in the country is going to miss a screening, they will get some kind of illness that would have been caught had they had that screening. Now, whether or not a year to 18 months or the time that normal healthcare services bounces back, if it ever does completely bounce back, happens, whether or not they would have gotten sick in that window of time, and the value of that is very hard to quantify. So we're sure there is an impact of it. We're still working through what the final quantification of that's going to look like. But right now, do your best to maintain those wellness plans as much as you can, stick with them, and we're going to try and come up with a quantification of that at some time, hopefully soon. So with that, I'll turn it back over to Patrick to talk about the carrier view of COVID-19 and the market response.
Thanks, Nick. And just if anybody has questions, feel free to post them on the chat feature, and we'll try to address it at the end. So the question is, from a market perspective, how have the carriers responded to the claim disruption? Well, what we're seeing is some carriers providing refunds as a result of the COVID crisis. It's more common on the dental and vision side. Delta Dental, Blue Cross, many others have announced some form of a refund for dental and or vision coverages. But on the medical side, right now, United has provided a refund for Rhode Island fully insured groups. It's 5% refund for 1 month of premium and 10% for small groups. The other medical carriers are evaluating this. Nothing has been announced yet. Our view is that it may be a preventive ability to stave off the MLR refunds that might be needed at the end of the year. So it's just might be good press for them if they're looking like there might be a MLR refund. As we look forward to the 2021 rate review process, the OHIC rate filing deadline has been delayed until June 18th. So next week, actually literally 1 week from today, the carriers will need to be submitting their renewal rate increases for 2021. Now, nobody knows what's going to end up happening here, but it'll be interesting to see how OHIC is going to factor in the claim costs for that March to May timeframe in their review process. What our anticipation is that final rates may be further delayed and might not be approved until mid-September. So, keep in mind that there might be a little bit of a delay in receiving those 1/1 renewals for those employers that may be on a 1/1 cycle. Looking to 2021, fully insured groups, we're focusing on the fully insured right now. Groups will need to be proactive. They should anticipate a condensed timing. A number of employers may have an aversion to disruption for the employee population, given what's going on, and may be hesitant to switch carriers. However, on the other spectrum, some employers may have significant cost pressures and may be focused to market proactively in advance of renewal receipt. So it's going to differ based on what approach a company has and where they stand from the cost pressure perspective. From the carrier perspective, there is significant uncertainty in how the carriers will be underwriting renewals. And speaking with each of the carriers' underwriters, they still are unsure of the methodology that they're going to be employing for 1/1. There's multiple underwriting approaches that are being investigated, things like shifting of the balancing of current and prior years' experience, potentially looking at 3 years of experience, potentially applying factors to the March data forward to try to normalize that data. But just keep in mind that this uncertainty typically means a more conservative approach when it comes to underwriting. We're saying that it's going to be more art than science this year, just because of trying to get to that right number. It depends on what you're looking at and kind of figuring out what feels right. Now, on a positive note, and having absolutely nothing to do with COVID-19, there is good news for employers in that the HIT tax is being pulled out for 2021. Now, what this means is it should be a 1 to 3% reduction in rates depending on the plan type and the carrier. But that is something, basically your starting point is going to start at a -1 to a -3 and then build from there with trend and everything else. Now, for self-funded plans, there are similar challenges to the fully insured plans in that they need to accurately determine the anticipated claims for 2021. Now, two factors to account for include the potential increase in utilization based on deferred care if it comes in higher than anticipated, and also the need to resist understating those working rates based on the suppressed utilization patterns from March forward. So both of those things need to be taken into account when you're estimating your claim projection for the coming year. Now, from a stop loss perspective, we anticipate there will be very little impact to the specific stop loss rating. Most of these claims are acute claims. They're obviously not recurring claims. However, your aggregate stop loss attachment points may have the same issues in the predicting of claims. So there may be an impact from the aggregate stop loss, whether there's going to be a second wave or an increase in deferred care. But by and large, the stop loss impact should be fairly negligible. Now, a question that we've danced around is how can emerging claims data be used? And we can make some assumptions on how to normalize a group's data. And I'm actually going to kick it back over to Nick to kind of go through some of the information that he's pulled.
Yeah, I'd say the point of this, more so than anything else, is that we have seen that the impact of COVID-19 on employers is going to be case-by-case basis. So Kate, me, Patrick, we don't really like to be cynical when it comes to talking about insurance companies. We think, by and large, they're trying to do good. But they don't have, given the client base they have and the sheer volume of premium, they don't have the resources to do case-by-case adjustments for COVID-19 for their entire book of business. We do. The reason that's important is because, as I mentioned, nationally, we're thinking that the total impact to clients is going to be flat to slightly favorable. That doesn't mean that's going to be the case for everybody. Here's a case I put up here for a group whose experience we've seen in part and have projected some. The gray bars represent the expected number of months in a year that we expect their costs to fall somewhere in the range on the axis on the left side. Okay, so you can see that we expect their cost to be right around that 1,066 to 1,090 per employee per month, with a window of space around that, where like the outside expectation in a normal month is somewhere anywhere from $930 to, on the high side, $1,220. Okay, you can see their actual experience prior to COVID is in green, and it very much follows the expectation, right? The gray bar. But when you look at the COVID months, they're a little bit outside the expectation window, as you can see. In fact, the probabilities that months of claims in those ranges would occur are extremely small, which is what tells us that we know that there was a COVID impact in those months. And in fact, this is one where the drop-off is so much that we would recommend a mid-year adjustment, and that we would definitely have to make some kind of normalization and adjustment for their underwriting for 2021. So in other words, what we're saying, and you'll hear more from Patrick about this towards the end, is that it's important that when you get, and this matters whether you're fully insured or self-insured, when you get that renewal from your medical carrier, it's important to be skeptical about it, and not for cynical purposes, but for the purposes that your business could benefit by making sure that you're having adjustments to your underwriting that are specific to you. I don't care how small you are. Most of the time, your experience has enough credibility to make some kind of adjustment, and if it's favorable to you, you should make sure that that adjustment does find its way into your rate. So I wanted to share that. I thought this was kind of an interesting graphic, and this is one of the ways that I've been looking at things, and we have this capability to do this for all of our clients. It's just that the insurance companies, as big as they are, don't have the resources to do something like this on a case-by-case basis, so they apply book of business factors, and that may not benefit you.
Thanks, Nick. As Nick had indicated, what's really important is having that independent underwriting for their renewal from various formulas to identify what a fair renewal is for 2021. And again, to Nick's point, we're not trying to be cynical with the insurance companies. We just think you need to evaluate, just with all the unknowns, we think it's important to evaluate and identify some of those alternative assumptions regarding the renewal factor and claim projection for your organization. It might be able to identify some savings with the carriers, as well as, one of the things that we look at is that large claim review. If these are acute care claims related to COVID, or maybe even not related to COVID, that's going to be important in identifying what the proper renewal is for your organization. Now, after going through this, if at the end of the day you're hit with some budget targets that still don't get you where you need to be, you are going to need to be looking at plan design, employee contribution changes to consider. And we'll obviously recommend that you benchmark your program from a benefit cost and employee contribution perspective to ensure that any changes you make still maintain a competitive benefit offering. But really, most importantly, is trying to get to that right number, given all of the cost issues that are going on with companies right now. It's never been more important to try to really squeeze all of the surplus out of your renewal calculation. So with that, we've left 20 minutes here for Q&A. So if there are any questions, if you can post them, we'd be happy to answer them.
Okay, great. So as we are taking a look at the questions, I'm actually going to pull down, I'm going to stop sharing my screen so that I can see the Q&A panel.
Can we ask questions verbally?
Joanne, are we able to ask questions verbally, or do we need to take them through the Q&A panel?
For the attendees, you need to type in the question through the Q&A panel. If you are interested in speaking live, then I can switch you from an attendee to a panelist. You just need to put that in the Q&A, request in the Q&A.
Okay. So Al, since you are a panelist, I think you're able to ask questions verbally. So if you have any, certainly kick us off. But I would also encourage those that are watching, if you'd like to submit a question, you should see at the bottom of your screen Q&A, and you can type in a question there as well.
Okay, so my question is as follows, that one thing that we've learned during the COVID crisis is that people love telemedicine. The providers love it. In fact, it's helped keep primary and specialty groups afloat. Frankly, they would have had even more severe cash problems had they not had the insurers and OHIC not jumped in and made this available. However, and there is a however, when you look at a recent RAND study, it basically says of the telemedicine that's been done in over a year, I think from a claims perspective, about 12% of it was actually reduced cost. That is, move services from a higher cost environment to a lower cost environment. 88% of the claims were viewed as additions. In other words, services that might not have happened were it not for telemedicine. So adds to employers' costs and consumers' costs. So I guess my question is, as we see here in Rhode Island and actually across the nation, a move towards parity with respect to telemedicine payment. That is to say, there is a bill right now in the General Assembly here suggesting that a 5-minute phone call should be paid at the rate of an office visit. What are your thoughts about that, Nick or Patrick?
I'm happy to take that. So a few things on the RAND study, and I appreciate the question, Al. Even with that, let's just use a 90-10 rule. 90% of the services were additional services and only 10% replaced. The average cost of a telehealth visit is around $50. Sometimes a little more, sometimes a little less, but let's just say it's around $50 for a PCP telehealth visit. Under the traditional model, this is not looking at the reimbursement rate issue that you brought up at the end of your question. But even in that perspective, so you're basically paying $50 or $500, 10 times 50 visits to replace one ER visit where the average reimbursement is $1,500. So that's still a pretty strong ROI if that one visit that's being replaced is that ER visit. So there is some savings that are being delivered, even though there is that increased utilization of telehealth. Now, I will say this, that telehealth before March of this year and telehealth since March of this year is going to be completely different. Because again, you're typically going to services like Amwell, like Teladoc, the designated providers of it. And now we're actually being able to working locally for that and for that reimbursement. The concern is the reimbursement rate that you pointed out. The reimbursement rate for an office visit versus a 5-minute telehealth visit is dramatic. One of the ideas of telehealth is to provide a reduced cost on that. And that could have a significant cost impact from two reasons. People obviously would want to go to their local provider if they can, given the choice. And number two, it's going to be reimbursed at a higher rate, which will result in higher claim costs and higher, overall utilization costs for employers. So that's part of the concern with that legislation, in that you're not bearing the same fixed costs for providing the telehealth visit that you would need to for an in-person visit, and that's kind of our concern with the reimbursement set at the current rate.
Thank you.
Okay, great. So I am not seeing any questions come in through the Q&A panel. So we do have a few minutes. If anyone has any questions they'd like to submit, please feel free to do so. So it may be that all of the questions that we had were answered. Joanne?
So maybe one more? One more from me?
You have another one?
Okay.
Yeah.
So you guys covered 2020 pretty well, but the recent, I would say in the last couple of days, Anthony Fauci's comments about the expectation of a spike and a fall COVID, which clearly will spill into 2021 operations. Any thoughts about that? I mean, your guess is as good as mine, but my sense of this is that if you've got, first of all, I think that the flu for a given year is baked into anyone's experience, because that happens every year. But it strikes me that the additional COVID-19 that might happen, let's say in November or December, and roll into 2021, or the stuff that might happen in 2021, and the, God forbid, anybody gets flu and COVID, strikes me as, I mean, those projections that you guys showed will dramatically ramp up, I would think. Any comments on that?
Yeah, Nick, would you like to take that?
Sure, yeah. I do have thoughts about that. I think, Al, it's one of these things where it is going to be case-by-case basis. when we look today at a group's claims experience, as I mentioned, if we have their data through May, for example, we're able to detect at this point if that business is going to have an impact from COVID-19. And I think if we haven't seen one at this point for a particular business, which means that whatever cost they have had has been offset by avoidance of care, I would expect that's probably going to continue into 2021. For the groups that have had an impact, who have had a noticeable drop-off or a spike in cost because of bad luck industry, we would expect that trend to continue into next year as well. And the important question is, to what degree? So is it going to be a thing where it's the same as whatever they've experienced in April, May, carrying all the way till August or December of next year? We're modeling that. We think that is going to slowly start to not disintegrate, but the impact will get smaller and smaller each month. Maybe have another little spike again in April, May of next year, and then late fall, early winter of next year. So if you took a picture of what's going to happen this year, and then you copied and pasted it for 2021, and then you just squished it a little bit, that's sort of the expectation right now, because we do think even if it does spike again, we think that people will be more careful. I don't expect people are going to be shaking hands and hugging the same way that they've been in the past, frankly, which is probably sad socially, but probably good for COVID, which is, it's a shame for me. I like have a great handshake, so I'm kind of bummed that handshaking might just go away. So, I got mitts like jaws and power in these forearms. So anyway, so I do think it's going to continue. We have to look at the data, but for groups that have had little to no impact so far, I think they probably can expect little to no impact in 2021. And for groups that have had an impact, either good or bad, I think it'll be similar, but to a slightly less degree, and to what degree depends on what the data looks like. So that's something we do have the capability to measure, but it is hard to say. There's not a lot of good science on it right now, so we're all sort of going on judgment and assumptions, but we think and hope we're pretty good at that, and enjoy so far having tried to solve those problems for our customers.
Thank you.
Okay, great. So not seeing any other questions. I believe that you all should have seen a survey pop up on your screen. So I would just ask before you close the webinar, if you could respond to the poll. It's a brief poll, and we appreciate your feedback. And again, I very much appreciate your time this morning and hope that it's been helpful to you all. And I hope you all have a great day.